My name is Ádám, and I'm a third-year resident doctor in obstetrics and gynecology clinics. And I would like to present you my 12 months progress. Here you can see the list of my team members. And I would like to tell you my vision. That is, endometriosis should be a concept of the past with one pill a day. And I have, of course, I have a mission, and it sounds like to find the most effective pain relief therapy for endometriosis. We have two ongoing projects. The first one is already submitted, and it's in connection with the medical therapy for endometriosis, and the second one is in connection with the surgical therapy for endometriosis. Let's start with the first one. It's the comparison of robot-assisted versus conventional laparoscopy for treatment of endometriosis. It's a systematic review and meta-analysis. Why this topic is so important? Endometriosis carries a high individual and society cost. There's a high pressure and the growing need to treat with the most appropriate and the highest quality care. There's a lot of available therapeutic option, but let's focus just on the surgical interventions. Nowadays, we have two techniques what we can choose. The first one is the conventional laparoscopy, CL, and the second one is a little bit newer technique. This is the robot-assisted laparoscopy, that's RAL. We have a third option, but there's just a rescue option if we have a serious problem with the two before mentioned technique. Here you can see a list what robot offers to us. Reduced pain, less blood loss, etc., etc. But my question is, can we observe these advantages in the everyday practice? That's why we would like to compare the RAL and the CL for endometriosis surgery regarding the perioperative outcomes. Our question, is RAL safer and more effective than the CL in the field of endometriosis surgery? Our population is patients who underwent endometriosis surgery. Our intervention is RAL, the comparator is the CL, and our outcome is the different perioperative outcomes. Our hypothesis, of course, RAL is superior to the CL in the field of endometriosis surgery. And after the whole process, we can turn this knowledge back to the bedside, next to the bedside, and we can improve the surgical treatment of endometriosis. We conducted a systematic search in 3 online databases. Here you can see my search numbers and the very simple search key. At the end of the whole selection process, we got 13 eligible full text. Here you can see the list of our perioperative outcomes which we investigated: intraoperative complications, postoperative complications, operating room time, operative time, estimated blood loss, number of conversions, number of rehospitalizations, and length of stay in hospital after the surgery. Surprisingly, we can't observe any significant difference between the two techniques, except one. So I bring you this important figure to you. What we can see here, we compared the RAL and the CL regarding the operative time, which was measured from skin incision to the wound closure in minutes. What we see here is the RAL lasts about 30 minutes longer than the conventional laparoscopic technique, and this is not what we expected. Here you can see my baseline characteristic table. I would like to highlight we had only one RCT, and the most of our cases was retrospective study. And another thing what I would like to highlight is there was a high heterogeneity regarding the severity of endometriosis. What's our conclusion? For endometriosis surgery, RAL does not have statistically demonstrable advantages over CL in terms of perioperative outcomes. And what we suggest for the everyday practice, CL should be the first choice. but my own suggestions, and in the discussion part we more detailed talk about this topic, so it's not so easy to answer it with just one sentence. And our implication for research, we need to do more randomized studies and need to investigate the medio-economic impact. We already submitted to the second target journal our manuscript. It was 2 days ago to the surgical endoscopy. The first target journal was the British Journal. I think we got a very good reviews, but we are not matchy-matchy. So far we talked about the surgical techniques. Let's turn to the medical therapies. Investigating the most effective medical treatments for endometriosis-related pain. It's a systematic review and a network meta-analysis. Almost every 10th woman suffering from endometriosis. The symptoms can be very diverse: dysmenorrhea, pelvic pain, dyspareunia, and so on. There's a lot of therapeutic options, but at this time we focus on the medical therapies. We can divide it to hormonal and non-hormonal ones. We choose the follow-up time based on the hormonal treatments limitations, because there's some serious ones. It was 6 months. Here you can see the list of our therapeutic options, what we investigated. The size of the green bubbles represents the estimated effectiveness of the drug types. Combined oral contraceptives, gonadotropin-releasing hormone antagonist, gonadotropin-releasing hormone agonist, progestins, aromatase inhibitors, selective estrogen receptor modulators, NSAIDs, and opioids. Our question was, which is the most effective therapeutic option for endometriosis-related pain? Our population, women of fertile ages with endometriosis. We compared the before-mentioned medical therapies, and our outcome is the endometriosis-associated PELV on different pain scales. Our hypothesis, oral combined contraceptives are superior to the other therapies for endometriosis-related pain. And we would like to increase the effectiveness of pain relief for endometriosis. We conducted a systematic search on 3 online databases. Here you can see my search numbers, and I highlight you the 4 big boxes of my search key. At the end of the selection process, we got 47 eligible full text. We already finished 2 or 3 days ago with all part of our manuscript, and our target journal is reproductive biology and endocrinology. But we need to polish the manuscript, and I think it will just submitted in September. And to summarize it, the most important thing is, I think, to finish my first project, and after that I would like to polish these little things with my second project. Thank you for your attention.
Thank you for the presentation. I would like to ask about what do you think about the concept that the endometriosis is a psychosomatic disease and should be treated with psychological treatments and even psychiatric treatments?
Thank you for your question. Yes, of course. If we dealing with endometriotic or endometriosis patient, it's very obvious to this problem, this disease is very complex, and not the first choice option is the radical or invasive interventions, and try to start with the less invasive techniques, for example, what you mentioned, and after that the medical ones, and the last step should be the surgical intervention. So my answer is, of course, this should be part of the therapy almost in every case.
And do you plan to investigate other treatment options apart from the medical and the surgical? Or, I mean, in your research, or not?
In our two ongoing projects, we're not dealing with this point of view, but maybe in the future, because if we close these topics, the surgical and the medical treatments, we need to go in further and further. So maybe that should be the next step to complete our topic. Thank you.
What's your personal opinion? Because I know that you are a member of the robot surgeon team. Is there any advantage of the robot-assisted surgery superior than the laparoscopy in the point of view, surgeon's view, for example, which is not measured in the publications?
Yeah, we only can write it and describe what you mentioned, these kind of things what we can't measure, just tell and feel. For a patient, it's not so important, or if you think further, it could be that if you ask a surgeon who tried this technique, it's more comfortable. And if you need to stand for 4 or 5 hours in a very rigorous position, it's a huge thing, a huge part of an operation to how the surgeon feel themselves under while a 5 hour, and how can they concentrate on the operation. So yes, of course there's unmeasurable things, and maybe in the future there will be techniques which can measure or something, kind of scores what we can use to highlight these things what you mentioned.
You said that it was a surprising result to have a 28 minutes plus to the robot-assisted intervention. Do you know, or do you hypothesize what the reason behind this could be?
Yes, maybe the surgeons who make these interventions, they spend their life with the older techniques, the CA techniques, the conventional laparoscopy. And if in the future they will use it for more than 10 years or 15 years, these results, these numbers will change absolutely in a different way. And if we make a discussion about this in 2013, it will be absolutely different result.
My question is to this, so it's an additional question. So, is there any, or did you account for the experience of the surgeons in the studies? Sometimes there are numeric data for how many surgeries they did before. Could you account for this?
Yes, if I understand you correctly, they measure the experience of the surgeons, or not?
Yes. Were there any factors?
Yeah. So in some paper, there's no information, and the other half mentioned that the surgeon was well experienced in the field of endometriosis surgery, but not numerically described this aspect. So there's no certain numbers, sadly.
Do you use this, both of these surgical techniques in your clinic?
Yes, for endometriosis not, but in general gynecology operations or interventions, yes, almost in everyday practice.
So for endometriosis, do you use the laparoscopy?
Yes. But in the future, in the near future, from September, from October, we would like to try it, but need to learn special tools, equipments to make robot-assisted endometriosis, for example, vulvar resection, and need to learn this plus tools and equipment. That's the reason why we not started with endometriosis. We first tried with general basic interventions like hysterectomy, and after 1.5 years we try with harder ones like endometriosis operation.
Okay, thank you very much.